In this presentation, we are going to see the development of gastrointestinal tract. The presentation consists of two parts. The first part deals with the formation of primitive gut and the derivatives from the foregut. The second part of the presentation will have the explanation about midgut and hindgut. We will cover this competency in this presentation with uh, deals with the development of the gastrointestinal tract and the common congenital anomalies. These are the learning objectives: formation of primitive gut and its parts. Then we will see the derivation, the structures derived from the foregut. Uh, now the remaining objectives will be covered in the second part of the presentation, which will involve the midgut, its rotation and its structures derived from it, and the structures derived from the hindgut. We will also see the embryological basis for the blood supply of the gut, and as I mentioned earlier, the common congenital anomalies associated with the tract. To understand the formation of primitive gut and the body wall, we should recall the event which takes place during fourth week of development, which is the folding of the embryo. And to simplify this, I am correlating this with an example here. Now imagine this is a sheet of paper, and this is the longitudinal plane of the paper, and this is the transverse plane of the paper, and we will fold this sheet of paper in both these planes. So in this figure, you will appreciate that the folding is taking place in the longitudinal plane. So if this is the cranial end and this is the caudal end of the paper, so both the ends have folded downwards. So this end has come downwards here, and this end has come down here. So the cranial end has turned downwards like this, and the caudal end has also turned ventrally. So this is in the longitudinal plane. Now let's see if we fold this paper in the transverse plane. The two edges here of the sheet, if we fold in transverse plane downwards, they turn downwards and come here, as you can see here. Now you have to imagine that if we are folding this sheet of paper this way and also this way, so what do we get? We get a tubular structure like this. So this will be the cranial end and this will be the caudal end, and it becomes a tube as the two lateral ends in the transverse plane will fuse to form a tube. Now we will correlate this with the germ disc before it begins to fold. Let's get oriented. In the first figure, the amniotic cavity has been cut open. So what you are seeing here is the cut edge of the extraembryonic mesoderm, and that's the amnion which has been cut open. And what you are seeing here, this is the germ disc on the dorsal aspect. Now, if we take a transverse section uh, of this disc, which is represented here, and longitudinal section is represented here. In the first figure, this is the cranial end and this is the caudal end of the germ disc. You can see the oropharyngeal membrane here, and you can also see the cloacal membrane here. In the longitudinal section, you can see the oropharyngeal membrane here at the cranial end and cloacal membrane at the caudal end. Of course, you don't see these in the transverse section. So what we have seen the germ disc in the previous slide, that was before the folding. You can see it here again in the transverse section. This is before the folding. Now the folding begins in the second figure here, and it continues in the third figure. You can see the, due to the fold in the transverse plane, the two lateral folds, the lateral folds are formed, which as the folding will continue, they will approach each other towards the median plane ventrally. All these folds are ventrally. This is the yolk sac here. So the folding is towards the yolk sac. Have a look here. In this, the further folding has taken place. The two lateral folds are fusing. In this fourth figure, the lateral folds have fused. So the entire germ disc has become a tubular structure. Now if you recall, or you can see here, these lateral folds have an outer ectoderm and inner endoderm, and in between these two germ layer there is the mesoderm. So as the two lateral folds of both the sides fuse here, the corresponding germ layers of two folds will meet, and that gives rise to, you can, the primitive gut, because of the fusion of the endoderm gives rise to the primitive gut. The fold, as they fuse, they will give rise to the ventral body wall covered with the ectoderm. So as the two lateral folds fuse, there is an outer covering of the ectoderm, there is a tube there, and there is another tube which is the gut, which is within the inside the embryo. Let's see the same changes in the longitudinal plane, in the longitudinal section. So I have explained this earlier. Now this cranial end will turn downwards, the caudal end will also turn downwards. In the second figure it has begun, the cranial and the caudal ends are folding ventrally towards the yolk sac, and as it continues, uh, the structures which were here, the oropharyngeal membrane, the uh, developing heart and the pericardium, they come ventrally. This will be discussed later on in the cardiovascular system development. So notice that as it folds, the at the cranial end there is formation of foregut. At the caudal end there is formation of hindgut, and what we have seen in the previous slide, the the fusion of the two lateral folds, it takes place at the cranial end and the caudal end. In the middle of the embryo, the lateral folds do not fuse and it communicates with the yolk sac. And this part of the gut which communicates with the yolk sac is midgut. So that's the primitive gut, having the foregut, midgut communicating with the yolk sac, and hindgut. Obviously, the two lateral folds in the transverse plane, which I was explaining in the previous slide, that they fuse. The fusion takes place in the cranial end and the caudal end, but in the middle part it does not fuse, and for some time, which will later fuse to form the ventral body wall. Let us see this three-dimensional figure showing the embryo after the folding of germ disk has taken place. So let us try to see the figures, the structures here. That's the foregut at the cranial end. That's the oropharyngeal membrane at the cranial end. That's the hindgut in the caudal part, and that's the cloacal membrane in the caudal end. The structures, due to the folding, all these structures have changed its position. In between the caudal end and the, sorry, in between the cranial end, this is cranial end, and the caudal part of the gut communicating with the yolk sac is midgut. So as we have seen that during the folding of the embryo, the two lateral ends, lateral folds, curve ventrally towards the median plane and fuse with each other to form the ventral body wall. But what happens if these two folds fail to fuse? So these were the two folds and they approach each other towards the median plane, and eventually they will fuse to form the ventral body wall. But if they don't fuse with each other, so the ventral body wall will have some defect. And these are the two defects in the abdominal region. We are going to see these two in the coming slides, the omphalocele and gastroparesis. If this defect happens in the thoracic region, it results in ectopia cordis. So the heart remains outside of the thoracic cavity. Another defect is extrophy of urinary bladder, where the bladder wall remains exposed to the exterior because of the defect in the ventral body wall. You will study this during the development of the urinary system. Let us see the various parts of the primitive gut. This figure is representing the embryo in mid sagittal section. And we have seen that it consists the primitive gut consists of foregut, midgut and hindgut. This classification is based on the arterial supply of the gut, which comes from the dorsal aorta. That's the dorsal aorta. The foregut, the abdominal part of the foregut, is supplied by the celiac trunk. I'll come back to this again about the blood supply of the foregut. So the abdominal part of the foregut is supplied by the celiac trunk. The midgut is supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. All these arteries are coming from the dorsal aorta. Part of the foregut which is extending into the head and neck region and thoracic region, the blood supply is not from the celiac trunk. Note that the derivatives in the head and neck region will be covered in with the head and neck. So we will concentrate in the abdominal part. So the junction of the midgut and the hindgut is at this point where the hepatic bud is opening. If you recall from the gross anatomy, the junction of foregut and midgut is where the common bile duct opens into the duodenum, and common bile duct is formed by the hepatic bud. We'll discuss that later in detail. So here is the foregut ends and the midgut begins, and midgut will continue with the hindgut where the allantois is opening into the hindgut, and the hindgut opens into an endoderm lined space, the cloaca. So that's the hindgut. Okay. Another thing to notice in this figure is, as we have discussed earlier also, the midgut is in communication with the yolk sac. That's the yolk sac here. In the previous figure, in the previous slide, you have noticed that the communication is quite wide. Later on, the communication between the yolk sac and the midgut narrows down, and it is called vitelline duct, and it is present in the umbilical cord. That's the umbilical cord here. So these are the parts of the primitive gut. The primitive gut is suspended to the posterior abdominal wall with the dorsal mesentery, and it is suspended to the ventral body wall by the ventral mesentery. Later, most of the ventral mesentery will disappear. You can see here in the neck, here there is no ventral mesentery except for uh, the abdominal part of the foregut. So in the second figure you can see here the dorsal mesentery, but you don't see the ventral mesentery. Let's see in the other figure. That's the blue colored structure here. This is the dorsal mesentery, which suspends the gut to the posterior body wall. You can see the ventral mesentery here, which suspends the gut to the ventral body wall, the anterior body wall. You can see that the ventral mesentery is shown in the abdominal part of the foregut. Based on the relationship between the abdominal organs and the peritoneal cavity, the abdominal organs are classified into three groups. The intraperitoneal organs are the organs which are surrounded by the peritoneum and they are suspended to the posterior abdominal wall by the dorsal mesentery. Another group is the organ which lies behind the peritoneal cavity. These are called retroperitoneal organs such as kidney. You can see here the organ is behind the peritoneal cavity. Uh, Ignore this at the moment. So the retroperitoneal organs will be like this. Example is kidney. Now there are secondary peritoneal organs. Secondary retroperitoneal organs. Now what are these organs? These organs are initially uh, intraperitoneal, just like what you see here in figure A. Later, the mesentery of these organs will fuse with the parietal peritoneum of the posterior abdominal wall. You can see here that's the dorsal mesentery and that's the parietal peritoneum of the posterior abdominal wall, and they get fused and this portion, fused portion, will degenerate and then the organ becomes retroperitoneal. So such organs which are initially intraperitoneal and later they become retroperitoneal, these are called secondary retroperitoneal organs. Example is pancreas, ascending colon, descending colon, duodenum. As we know that when there is folding of the embryonic disc, it is the endoderm which gives rise to the primitive gut. And which is in communication with the yolk sac. The endoderm will give rise to the lining epithelium of the gut, and it will also give rise to the parenchyma of the glands which are derived from the primitive gut, such as liver and pancreas. So as the this endoderm cells will proliferate. So initially what happens is the primitive gut is hollow. Then there is proliferation of the endodermal cells which makes the gut as a solid structure, and then there is a recanalization, and then there is formation of a definitive lumen in the gut. Now if there is a problem in recanalization, it leads to stenosis of the duct, the stenosis of the gut, in which there is, if this is the normal lumen, there is partial narrowing of the lumen. It may also cause atresia, and in this condition there is complete obliteration of the lumen. So what are the derivatives of the foregut? That's the list. You can see that this blue colored part of the gut is the foregut, and these are the derivatives of the foregut. We are not going to discuss all the derivatives in this presentation. This will be done with head and neck. This will be done with the respiratory system. These are part of digestive system, but we are not discussing this in these three organs in the current presentation. So we will focus on these three: the esophagus, stomach, and duodenum. The esophagus develops from the foregut, uh, distal to the respiratory diverticulum. This diverticulum also comes from the foregut. This will be discussed in the respiratory system. The diverticulum gives rise to trachea and the bronchial tree. So distal to this part of the foregut will give rise to the esophagus. Of course, distal to that is the developing stomach. So the esophagus, its epithelium and esophageal glands are derived from endoderm, whereas the connective tissue and the smooth muscles comes from the splanchnic mesoderm, which is around the primitive gut. The skeletal muscles of the esophagus, they are derived from the branchial arches. As discussed previously, the lumen of the esophagus recanalizes, and if there is a problem with the recanalization, can lead to esophageal atresia. The If this happens, the fetus will not be able to swallow the amniotic fluid. As a result, there is accumulation of amniotic fluid causing polyhydramnios. Such babies, when they are born, they are unable to swallow and they regurgitate the feed immediately. Let us see the development of the stomach, uh, which also develops from the foregut, just distal to the developing esophagus, as it is seen as a dilatation in the foregut, fusiform dilatation in the foregut. Uh, you can see here, that's the developing stomach. So this is mid sagittal section. It has anterior surface attached to the ventral mesentery. It also has the posterior surface attached to the dorsal mesentery, and the surface which we are seeing here will be its left surface, and opposite to that will be right surface. Now as it further develops, it will undergo disproportionate growth and it will rotate along two axes to acquire the adult position. Let's try to understand these changes. Let's see the first figure here. That's the developing stomach, fusiform dilatation in the foregut. So here is the ventral mesentery attached to the anterior border of the stomach, and that's the dorsal mesentery. Now this line here is, arrow here is representing the vertical axis, which will pass which will pass vertically through the stomach, and if you look from above, then the rotation takes place in clockwise direction, like that. So it will rotate in clockwise direction, and during this rotation what will happen is the borders and surfaces of the stomach will change their position. So the anterior border, which was facing anteriorly, will give rise to lesser curvature after the rotation, and the posterior border will give rise to the greater curvature. You can also see the greater curvature here. The posterior border grows more than the lesser border, so hence it is bigger than the lesser curvature. As the rotation takes place, the two vagi, uh, right and left, will also accompany the corresponding surface of the stomach. So the left vagus, which was supplying the left surface of the stomach, will supply the anterior surface after the rotation, because the left surface becomes the anterior surface of the stomach. And the right surface of the stomach after the rotation becomes the posterior surface of the stomach, and it will be supplied by the right vagus. Now as this rotation takes place, as the borders and surfaces of the stomach will change their position, along with that there will be change in the position of the mesenteries also. So the greater the dorsal mesentery, which was here, becomes greater omentum, and the ventral mesentery will become hepatogastric ligament, or the lesser omentum. And as this rotation will take place, a space is created behind the stomach, which is the lesser sac, or the omental bursa. Now these are the changes taking place due to the disproportionate growth of the borders of the stomach and rotation along the vertical axis. Now the stomach also rotates along the anteroposterior axis. So this arrow here is representing the anteroposterior axis. Anteroposterior axis will pass through the stomach from here, and if you see from front, it will rotate clockwise. So the stomach will, these arrows represent the showing the clockwise rotation. So due to this rotation along the anteroposterior axis, the upper end of the stomach will shift to the left and to the um, goes little lower and to the left, this one here, and at the same time the lower end will shift to the right and it moves little upwards. And with these changes the stomach acquires the adult position. The epithelium and the glands of stomach are derived from the endoderm, whereas the connective tissue of the lamina propria, submucosa, and the smooth muscles, they are derived from the splanchnic mesoderm. Let's see the changes in the stomach during the development in another view, that is the transverse section. So if we take a section here, we will see the developing stomach in this figure like this. So here is the stomach, that's the dorsal mesentery, and that's the ventral mesentery. You can notice that in the dorsal mesentery there is a spleen developing, and in ventral mesentery there is developing liver, but we will not discuss that part here. So let's focus on the stomach. So that will be the left surface of the stomach, that will be the right surface of the stomach, accompanied by their corresponding vagus nerve. So as the rotation takes place along the vertical axis, the left surface becomes the anterior surface and the right surface becomes the posterior surface. The ventral mesentery becomes the lesser omentum, and the dorsal mesentery will become the greater omentum. You can also see that there is creation of the omental bursa or the lesser sac during this rotation. Hypertrophic pyloric stenosis is a congenital anomaly which results from the hypertrophy of the circular muscles in the pyloric region of the stomach. And due to this hypertrophied muscle, the lumen of this pyloric region of the stomach is narrowed down and the gastric content cannot pass through it. So have a look here, the normal stomach, here is the pyloric region and the normal lumen. In this figure there is hypertrophied circular muscles, and due to this the lumen is occluded and the gastric content cannot pass through this. As a result, uh, the baby will have distended stomach, and the content, gastric content, he will vomit with force, which will be resulting in projectile vomiting. The vomiters will not have bile stain because there is no mixing of bile till now uh, in this part of the gut, and this mass due to the circular muscle can be felt on the abdomen of the baby in the upper part uh, on palpation, and sometimes the peristaltic movement can be seen on the abdominal wall in this direction. The condition is treated surgically. So here is the in the figure, in this figure, abdominal incision is made and the hypertrophied part of the stomach can be seen, and here during the surgical treatment the circular hypertrophied circular muscles have been incised. This is treatable condition.